Good afternoon, everyone. My name is BC. I'll be the one moderating this session. I would like to start with the land acknowledgement. The city of Halifax is situated in the Mi'kmaq ancestral and traditional lands that belong to the Magma people. I want to welcome us all to this session. The title of the session is Finding a Better Way, a Harm Reduction Approach. And we have three presenters, that'll be enlightening us about what's happening in this space. Each presenter will have 20 minutes, and I'll start by calling on Sandra. I'll leave her to do a proper introduction of herself, and she'll be anchoring the session that says effectively supporting unhoused individuals who use crystal meth. Thank you.
I start with bank. Hi, everyone. I'm going to try to keep on time as this subject is near and dear to my heart. And I normally edit my presentation up until the night before, but as you can see, there is a mistake in the title that my team asked me not to correct. We're missing the unhoused part, which I actually think speaks to our philosophy at work. I know this conference is about homelessness, but we're really trying not to see the community we work with in terms of their housing situation. I feel people very frequently get labeled the homeless or the unhoused, and even though that's the population we're focusing on, the focus is really on connecting with individuals and making meaningful relationships in order to support, I feel, like subset of the population that gets easily disconnected from services. Oops. Sorry, my screen here is not moving with that. So this is what we're going to be talking about. My hope was to encompass programs that are already actively working with individuals using crystal meth, as well as programs that don't necessarily have the awareness that they're working with stimulant users, but just acknowledge that they're seeing different issues than they used to. Yeah. I'm sorry, tech person. The slides are now the slides are moving here, but not there. Little help.
They sent out a thing saying you guys were supposed to, I don't know if anybody got it, they said you're supposed to wait for 15 minutes to start.
Oh. By the way, this was the only thing I was nervous about because I have no, that's the one thing I have no control over.
That's strange. Can we close and then let's close and reopen? Do you want to reopen?
Sure. But there seems to be a lag between.
Let's do it.
Oh my God, you're awesome. Thank you. Now I'm going to talk faster, and I apologize. Why this particular topic? I'm sure at least some of you are aware that this has been an increasing issue Canada-wide. At the same time, there's such a limited amount of actual confirmable data in terms of engaging with this particular population. I've seen an increase in the number of agencies, again, Canada-wide, who reached out because I ran a series of trainings in like 2017, and we did a webinar through Ontario Harm Reduction Network, and then different spaces were reaching out to figure out how this fits in with their work. And I would, as I mentioned, I feel like they fall into two categories: agencies and organizations that are aware that this a particular problem is related to crystal meth use and their lack of capacity to meet the needs of the community. And then agencies that kind of suspect there's an issue, but they can't really name it. Again, I spoke with a lot of folks who actually interact with this population, and I think we all agreed. Most of us developed some way of effectively working with people. The frustration is that this is not sector-wide practice because there is no data and there is no quote-unquote evidence-based best practices. Unfortunately, a requirement, especially for those of us working in clinical spaces. So that was one of the reasons my program, which is tiny, 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 we're an agency that serves population in downtown East Toronto. We see approximately 200 to 250 individuals each day, and we're total staff of 18. So this issue had to do with knowledge, capacity, and the team's desire to support the folks who are really cut off from other services. Why are we seeing an increase in crystal meth use? One of the biggest reasons is it's a synthetic drug. It can be made locally. It doesn't need to cross borders to get here. The price on the street dropped significantly in relationship to other drugs. And from speaking to colleagues, again, Canada-wide issues, but somehow we always have this trend where stuff starts out in the West, or awareness of it starts out in the West, and it's making its way slowly east across the country. And then in the context of the population we work with, I basically just talk to people to find out why are they using this as opposed to other things compared to before. So affordability, accessibility were two big things. The third was like very practical. People needed stuff that keeps them awake for prolonged periods of time so that they would be safe, because more and more people were not using shelter system anymore. They were street involved, sleeping in public spaces, or just spending a lot of time in public spaces and didn't have a safe place to sleep. And then the last thing is, I know this is very like medically and technical, but a half-life of a drug is the approximate amount of time that it takes your body to metabolize half of the amount that you consumed. Crystal meth has a half-life of 12 hours. Compared to MDMA, which is like 7 approximately, cocaine, which is usually less than an hour, which means A, you're feeling the effects way longer, but B, if you're taking it again while you still have crystal meth in your system, from purely biological point of view, the chances of overdosing are higher, and the chances of experiencing psychosis due to having too much crystal meth in your system increase. So this is just the context of our pilot. We were in a situation, I don't know how many of you work in drop-ins or interact with drop-ins, but they're kind of a unique way of delivering services. They're usually community-based. They're spaces that offer things like food and place to sleep and a washroom, and like ours offers like food care, nursing care, clinical management, connection to primary care, so it's kind of a one-stop shop. The other thing is we're low barrier space, and when I say that, I'm not using like fancy terms. You don't need to do anything, say anything, share anything when you're entering our space. You don't have to interact with staff. They kind of like just track numbers of people that we see. We don't collect any data until people are at a point that they're willing to share it with us. And again, I understand that's not an option in a lot of formally funded or clinical setting. We're all about data gathering, but that also excludes a lot of people from accessing our services. So two things happened. Because we're so low barrier, we started seeing a lot of people who, due to their quote unquote behavioral issues, couldn't go to other programs. We were one of the only 9 programs that was offering any sort of indoor space services during COVID. Meaning we had different protocols, different capacity. The staff were tapped out. The way they were delivering services changed. They no longer had the opportunities or the capacity to actually engage with people one-on-one. So we started seeing a lot of, again, I hate using these terms, behavioral issues, which we recognized were due to circumstances and also how things changed in terms of our service delivery. Again, when we talked to people, they identified that their number one thing was looking for housing. I mean, duh, if you're on the street, you want to be indoors. But it's also limitations of the system. They were not welcome in most indoor spaces, and when I say indoor spaces, like including public spaces. If you're prone to having crises, very quickly, the police force recognizes you, mall staff recognize you, library staff recognize you. We even had folks who were banned from accessing hospital care because of issues. So how are you supposed to change your circumstances when nobody wants to work with you? Or they want to work with you only on their terms, which you're not in a position to meet due to your circumstances. I mean, this is, again, for anyone who's worked with this population, this is very self-explanatory and logical, but I just wanted to share that. Like, this is the reason why we focused on this population. Again, not all programs can serve all people, but I feel when we're drawn to this profession, you know, we want to look at creative ways of bringing services to people that are frequently labeled as difficult to serve. So folks that we're working with, I mean, on top of that, it doesn't matter if you're homeless at any age, it's heartbreaking. But the piece that I was personally and professionally finding really difficult to swallow was that these were folks like in their late teens, early 20s, and like looking at them and watching them age before your eyes and having kind of community of care giving up on their future and connections. I don't know. There's something, to me, extra heartbreaking knowing that this person didn't even get a chance to start their life, you know, to figure out who they are, how they are. Like, we've just labeled them as difficult to work with. You know, you don't fit our model, so tough luck. Figure it out on your own. And I believe we can do better than that. Part of the reason I'm talking about this is also a population that was less likely to get housed. They couldn't maintain relationships with workers in the community because of, again, being labeled dangerous or violent. Agencies would be protecting their staff, you know, by cutting off services to these particular individuals. And again, I'm not blaming anyone. You'll hear throughout my presentation, I'm all about increasing safety for everyone involved. Like, I believe that we shouldn't have to choose between client safety and staff safety. There are ways to meet the goals of both if we're willing to go there. So this was our pilot project. We basically turned something that we knew already works in practice into a pilot project that we got funding from Ontario Trillium Foundation. And I know we're all like hurting for money. And if your programs are looking for like the kind of funding that allows you to actually gather the kind of data you believe is relevant, I highly recommend working with them. This was the only time in my career where somebody didn't set up my targets for me and didn't tell me what to look for. We were allowed to set up the research design based on the actual needs of our community, which was liberating and life-changing. So basically, the project consisted of us introducing a harm reduction case manager and a harm reduction worker. And again, I know other aspects of the conference focus on this, but the key of the harm reduction worker role was that it was someone who comes from the community and has lived experience without the label in their job title. You know, like, I believe we should value lived experience the same as education and pay people the same. So they're on the same pay scale as the rest of the staff working in the drop-in. They determine how much of their lived experience they're sharing with the rest of the team, and they're valued for that lived experience that they're bringing in. The reason we call this innovation is like we didn't determine the caseload for the case manager. It was basically how much time and energy do I have to support this particular subset of population. So harm reduction worker was embedded in the drop-in, and they would be the one kind of identifying which people the rest of the staff had a harder time connecting with. Honestly, people don't even have to disclose that they're using crystal meth. The kind of like behavioral overlap makes things very easy to spot. And then harm reduction case manager, connected them to whatever they wanted to be connected with at the pace they wanted to work at. So we didn't have timelines for when they're supposed to get housing, you don't have to get a primary care provider. They were the ones in charge of their journey, which, as we all know, is not typically the case with standard case management models. You're supposed to set the goals and you're supposed to keep people accountable. I mean, questionable how much it works with a lot of folks we work with, but with this particular group, definitely doesn't work. And one of the things that we were measuring was the length of engagement, especially when people were in crisis, because most research projects, most of our clinical spaces focus on the number of participants we're working with versus the time the case manager spends with people. So this was kind of the 3 goals that we had as part of our research. So maintain relationships with people at 1-year mark, which again, I know it seems so simple, but with this population, no one's done it before. Reduce the number of critical incidents, not just in our space, but in the community. Our corner was famous for being number 1 spot with the highest volume of 911 calls in entire Toronto. That's our claim to fame. And then collect information in such a way that we can present this as a proof that these are evidence-based, successful approaches. So this is the result, which again, didn't shock any of us. Every single person we engaged with, still, the project completed in August, and because we're continuing it, they're all still engaged with our program and with our staff. Number of critical incidents was reduced by 50%, and this was at 8-month mark. It was way higher at 1-year mark. The way I look at it, I haven't had to look at a critical incident report in months because we haven't had critical incidents in the space that used to have them daily, sometimes multiple times a day. The last 3 911 calls that we did in the last 3 months were all medical emergencies. We haven't had to call the police in months. And also we heard from the community that they have to call the police fewer times because a number of people who are continuously involved in these incidents are working with us and are actually housed. So they're housed, they continue to be housed, and we're hoping to continue this work for another 3 years. I bled tears for this grant. Do not apply for this one. But it was the only source of funding that would give us a chance to do this for another 3 years. The only expanding thing that we're introducing is we're collecting data and turning this into a training, which we're bringing to clinical settings. We're working with community agencies, but we've been having a lot of invitations to hospital settings. Physicians and nurses want to learn about this. Again, staff burnout. We recognize that there are so many barriers to delivering services in this kind of manner. But if you acknowledge the issues you might have, it's quite possible to introduce this model. I also have a couple of other slides that I'm hoping people will have access to. I don't necessarily need to share all the information, but I felt like if people have access to this and they can bring it to their teams, The other thing is my email is included in this. Please feel free to reach out at this point. I've done trainings and troubleshootings with organizations across Canada. I can do it for free if you don't have funding because I really believe in this. And part of the work that I do with you is trying to figure out how this can work for your respective teams, for your respective agencies, even if you're working in hospital setting. Sorry, I'm just like rushing through this. I know some of my colleagues will talk about this stuff as well. This is the only other thing I just wanted to highlight for folks who are not familiar with working with this population in the community. I find people's crystal meth overdoses frequently get focus as like behavioral issues, whereas they're actual medical emergencies. So if people are, sweating profusely, they can't breathe, they're acting extra agitated, please call 911. Instead of trying to get them to stop doing whatever they're doing, the risks of crystal meth overdose, they don't look as immediate as opiate overdoses, but they can be really scary and have serious consequences for people. So that's kind of like my only other important piece. And that's my contact info. Please feel free to reach out. I'll gladly respond.
Thank you very much, Sandra, for that presentation. There will be a question and answer time at the end of the presentation. So we have 2 more presentations to go. The next presentation is going to be handled by Matthew and Stephanie. It's on an integrated care model across community-based managed alcohol program and hospital-based addiction. I'll leave them to introduce themselves and their organizations. Thank you.
Thank you, everybody, for joining us. How do I get out? Okay. So I'm Matthew. I work at Projet Autochtone du Québec. I'm the housing manager there, accompanied by Stephanie. You want to introduce yourself?
I'm Stephanie Marsan. I'm an addiction physician at the Centre Hospitalier de l'Université de Montréal, which is a tertiary care hospital in downtown Montreal.
So what we're going to talk about today is I'm going to talk about my organization where I work, so PAC, Projet Autochtone du Québec. We're going to briefly talk about some of the needs of the community. I'm sure they're very similar in your communities that you work with too, so I'll go quickly over those. We'll talk obviously about our managed alcohol program. That's sort of why we're here. It's our harm reduction approach that we've developed. Stephanie's going to talk to us a bit about what the program has done so far, the results of some of the studies that we've done, and also hopefully some conclusions moving forward, where we're going, hopefully some things that can help you in your own communities that you're working with as well. So PAC is an Indigenous organization. We work with those facing housing insecurities in Tiohtià:ke, Montreal. We developed a culturally adapted approach based on empowerment, based on harm reduction, obviously. While traditionally our services have mostly been focused around housing and our shelters, through those programs we aim at providing well-being, healing journey, and focus on strengthening the sense of community throughout. So the needs, like I mentioned before, I'm sure you guys have seen similar needs in your community. I want to talk about these specific ones because it's sort of the starting point about where the MAP program developed, why we thought that we needed to develop something. So basically what we saw was people who were using our resources, using our shelter system, were increasing in age. We had more and more people who were elderly, having multiple health problems, complex both physical and mental health issues. Increased substance use, like you mentioned before. This is going back maybe 3 or 4 years when we first started reflection about what we wanted to develop. And it was essentially around alcohol in our community that we were dealing with. Other substances have definitely come across and taken a lot of space as well in the community that we're serving. But we're going to focus on alcohol for today. So I want to talk about some people who sort of, for me at least, inspired what program we developed. We try our best not to develop programs around individual people, but more the community needs as a whole. But of course, going into a project, you always have 1 or 2 people in mind that you hope will serve this project. So the first one that I worked with for quite a while was George. He was, again, he met all the criteria we mentioned before: elderly, multiple physical health problems, wheelchair-bound, alcohol use, very problematic as well. A long, rough life, lots of years on the streets. He developed this sort of hard-as-nails character as a protection mechanism, of course. But this one day, I came in to meet him, arrived super early in the morning. We were supposed to go to a hospital visit, I believe, and I knew I had to get there early to convince him to go. But he was up and waiting for me, which surprised me. He was waiting. It showed that he'd been up all night thinking about life in general. And we had this wonderful moment where he sort of opened up, allowed himself to be vulnerable, which was very uncharacteristic of him. And he just said he can't keep up anymore. The life in the shelter, the life on the streets, he just couldn't keep up. There's a wonderful thing that I'm sure those of you who work in the front line have seen is the sense of community that develops within our shelters, on the streets. Working with Indigenous populations as well, it's tenfold. Whether you're Mi'kmaq, whether you're Anishinaabe, there's a sense of camaraderie and brothership that develops within the community. And George, as one of the elders of the community, definitely was part of that. There was always someone who was willing, when he had to get his cigarettes, when he had to get his alcohol, someone would wheel his wheelchair up to the dep where he can purchase it. When he lost his bank card or forgot his NIP or his PIN number, I think half the community knew his PIN number to help him out. But the sense of community support was there for him. And this specific night, I think he realized that, he had more than just become a part of that community, but he'd become really dependent on it. He had been out drinking with his friends during the day. He's getting up in age. He can no longer drink all night. By 5 o'clock, he wants to come home and relax. But unfortunately, the people he's with, they're not ready to go home just yet. The party's not over for them. So he's just sort of stuck. And like he said, he can't keep up. So what do you do with people like George? He spent all night thinking about what his options are. Of course, private housing would be, he's someone with a pride. And of course, that's something that he would love. Unfortunately, his financial situation, his physical health situation meant that that's not in the cards for him. He would be excluded from the housing program. He needs the extra care that's involved. Long-term care facilities are also he's excluded from because of his drinking. He jokingly mentioned that, hanging out with the guys, he doesn't party hard enough to hang out with the younger group at the shelter, but he parties a bit too hard for the people in the old age home. So what's left for him? What do we do? And if he wants to go to the old age homes or the long care facilities that he needs the support, he'd have to address his drinking. And unfortunately, like he said, long life, many years on the streets. And he mentioned that, if I have to address all the issues that lead me to drink, the many, many years of trauma and abuse and everything else going on, he's like, I'm going to be here for 20, 30 years still, and that's just time I don't have. So we need something for him now. The next person is Simeoni, and I don't think our video works, unfortunately. But you can look it up online. This was a beautiful video made by Rapsim with Valentine Prou. It's just a small clip of a series of clips that sort of emphasizes the needs to develop different types of housing and different supports of housing. But Sim has been in the MAP program for a while, and in this video, she talks about sort of what brought him to Montreal. Stephanie will talk about Sam. We'll loop back to him later on in the presentation to check in on how he's doing now. So strongly suggest it. Look it up online. Les Meurtres qui nous habitent is the series of videos, and you can listen to Sim. Moving on. And now it doesn't work. Okay. So what do we do with the Simeonis and the Georges of the world? They find themselves aging out of the shelter, needing extra supports. We couldn't find anything in Montreal where these people could be housed and homed and find a place for themselves. So we decided, well, we have to develop it ourselves. We looked around, did some research. The MAP, the Managed Alcohol Program model, was something that we found super interesting. We were fortunate enough to talk, it's something that exists across Canada. We reached out to some of our partners to learn about what they've done. They've been super generous with us. Some of you may be here. But sharing their little bits of wisdom, what they learned in their experience. And the one thing that kept coming back time and time again is the importance of collaboration with medical services. makes sense. Of course, with the multiple health issues, the alcohol addictions, having that coordination is something you can't run the MAP program without that. Of course, we were super nervous because our experience in dealing with the homeless population, like you mentioned before, are excluded from many health services and connecting, and regardless of the fact whether there's little mobile clinics or outreach workers that do a lot, it's always on a piece-by-piece issue. There's really hard connecting to a long-term follow-up, and a lot of racial issues also involved, cultural issues, which act as barriers, which Stephanie will talk about later on as well. So collating this collaboration was not something that we thought would be really easy. So we ended up meeting the SHIM and Stephanie and her team, and they've been, I know the title is partnering, but they've been excellent in doing so. Just the presence of the house, they're there every week, which she'll talk about why they come every week. But they've really become part of the community, and really is not just a partner, not just someone that they go to have meetings with, but her and her team have become part of the community, that they've invested in that relationship with the participants. They come to our ceremonies, they come to our celebrations, and it's really done a lot to sort of push this program forward. So thank you for that. So with the SHUM and with PAC, what the model we came to put in place is our MAP program. So a lot of these points are very similar to other housing programs and ourselves, what we've already developed. So it's supportive housing. This morning there was mention of the wraparound services that are needed to, above and beyond just a roof over your head, what do we need to keep the person in housing? So there's intervention workers on site 24/7. We have caseworkers that are there to sort of provide the more in-depth follow-up that's needed. We try to also include other specialized services when needed, depending on the resident's needs at the time. Another thing that comes back time and time again when we talk to other MAP programs is the need to have community activities and animation to make sure that, despite the fact that the residents are coming to the house because of their alcohol dependency and addictions, it's important to make sure that the life in the house is not centered around alcohol. The life in the house is centered around the sense of community, the sense of help and support that they can give each other. So we provide animation, we do workshops, we do cultural outings, activities, try to make sure that the sense of culture is what's emphasized in our programs, because culture in a lot of ways is the medicine that helps them move on or above and beyond with alcohol addictions. And of course, a MAP program would not be MAP without the alcohol service involved. So that's where Stephanie and her team also come in, is the first evaluation, meeting with the participants, trying to understand what their level is, where they feel comfortable. Making sure that they're comfortable is the most important thing. So making sure that they're offered enough alcohol to keep them from experiencing those horrible side effects of withdrawal, but also keeping them at a certain limit where they're still functional within the house and within the program. So I'll leave it to Stephanie to talk about some of the access to difficulties.
So hello, everyone. So PAC really wanted, as Matthew mentioned, really wanted to have healthcare be an integral part of the program. And as we all know, community members have a very hard time accessing healthcare. They go through a lot of discrimination. They've been victims of racism. So, of course, they're going to have a lot of mistrust towards healthcare professionals and the health establishment. And, of course, because of that, they'll go to the emergency room at later stages of illness. They'll leave against medical advice. They'll miss a lot of their appointments. And so their illnesses will get more chronic, more complex, and go unresolved. So it was very important that we really try to find a way to provide those services within the program. And so with the partnership with our addiction medicine service, our team would go every Wednesday afternoon to the MAP program. First of all, it was more of a way to get to know participants, but also we wanted to evaluate their intoxication levels, their withdrawal, make sure that the dose of alcohol that they were being prescribed was adequate. And slowly but surely, they started to trust us a little more and to allow us to start looking more at their medical issues. What we also were able to do was liaise with pharmacies, because they, being disorganized, they would lose a lot of their health cards, their birth certificates, and so getting access to that medication was always a bit of an issue. So working with caseworkers, with the pharmacies, we tried to keep that on track. We would also facilitate the follow-up appointments with specialists. If they were lost to follow-up, we would try to get that back on track. So we would advocate for the clients, and we noticed that they started to get more involved. What really was helpful was that PAC also provided navigation services. So they would accompany the community members to their appointments. So they were accompanied by people that they trusted, which really helped quite a bit. And because this was a pilot project, of course, PAC wanted to evaluate and see, what if the program was actually feasible and if it was working, and to see what were the benefits and the obstacles. So we had researchers with many different skill sets from the research center at the CHUM, from the Université du Québec à Montréal, and from the Université de Montréal. And so for this research component, we had a qualitative section so we did a satisfaction questionnaire and semi-directed interviews for both staff and participants. And for the quantitative component, we did a retrospective chart review for a year before they came into the program and for a whole year following their admission to the program. And so these are preliminary results, but just within the satisfaction questionnaire of staff and participants, we really noticed a stabilization on patterns of use. So for those who were using non-beverage alcohol, they completely stopped using once they came into the program. They reduced their alcohol use. They reduced or even completely stopped any other substance use. We also noticed a marked effect on their health status. So the staff and the participants noticed that there was an improved adherence to medication. They slept better. Their personal hygiene was better, and they had an overall better general health conditions. But what really came through these satisfaction questionnaires was the fact that they came to trust the medical personnel. And the factors that really helped to develop that trust, what they said was that the team was accessible. So they knew that they were coming every week, whether it was the nurse or the physician or both together, they knew that they would be coming. And so they were accessible. They also felt like the team really respected them and that there was very easy communication so that they felt heard. And those were the main factors for developing that trust. On top of that, what we really noticed was that there was an improved relationship between staff and the residents, that there was much more, the participants also felt like the program became their home. So they were part of a family and they had a safe space for themselves. So it allowed them to reconnect with their cultures and their values. And we're running out of time. So perhaps I will just skip. So we did semi-structured interviews. With the retrospective chart review, we had 13 participants. 46% were Inuit, 54 were First Nations. Most had chronic illnesses such as COPD, hepatitis C, liver cirrhosis, cardiomyopathy. 3/4 had a mental health illness. And what we noticed was that over time, there was reduced alcohol use, a marked decrease in emergency visits, reduced number of discharges against medical advice, and an increased adherence to outpatient appointments. So just to finish, I just want to talk about Simiani, which Matthew mentioned as well, which really is a success story. So Sim is a 67-year-old Inuk man who has been homeless for many, many years and was drinking because he had a hard time sleeping and was very, very anxious of being out on the street. And he had very severe cataracts, so was blind and would be very vulnerable on the street, would get beaten up on a very regular basis and then go to the emergency very regularly. It was very well known by the emergency room staff. One night he meets an ophthalmologist who decides that, yes, let's do a cataract surgery, hands him a paper and says, we'll call you and we'll organize that appointment. Well, of course, not having a phone, not having a fixed address, they were never able to get in touch with him. They gave him a piece of paper with all the information to reconnect, but he's blind, he doesn't speak French, so of course, you understand that it went nowhere. But once he got into the program, the team was able to reconnect him to see the ophthalmologist. The PAC team was able to accompany him to his appointments. And so he did get that surgery. He got his medications. We made sure that the follow-up was made. So now he can read, he can see, he reads his newspaper every day. He has reduced his alcohol consumption, and he doesn't go to the emergency room anymore. So in terms of next steps, I think this partnership between PAC and SHIM has been amazing, but it's also shed a light on what there still needs to be done. There are so many projects, so many ideas, and so now what we're working on is developing a holistic and culturally safe environment at the hospital so that Indigenous community members can feel safe within the hospital setting. And PAC is also developing a unit with wellness beds so that that can help them transition from the hospital to the shelter, but have a safe space to get better. So just to finish, we would just like to acknowledge all the organizations, all the contributors, collaborators, researchers, caseworkers, intervention workers, everyone who's been involved in this program, because without them, none of this would have been possible. So thank you very much.
Thank you very much for that presentation. The third and final presentation for today is on increasing accessibility of integrated mental health and addictions care for the youth. This will be handled by Christine and Renee. After this presentation, there will be question and Q&A, where you'll have the opportunity to ask all the three, ask questions about the three presentations for today. Thank you.
Thank you. Good afternoon, everyone. I'm Kristen Kearney. I'm the Executive Director at Wyndham House, which is in Guelph, Ontario, and this is Renee Carpino. She's our Program Director. I'm having the same issue where I can't see what's up here. Did I just
Exit
and then go to this one, maybe? Oh,
Yes.
there we go.
It's just not matching.
There we go.
Now it's showing my presentation.
Yeah.
Is it this?
That's the new one? Maybe it's just that. It's this right here. Yeah. Yeah, that's great, thanks. Okay, sorry for that. So having gone to many of these CAH conferences over the years, I've certainly had different interests in different programs. I want to know more about how they got funding, how it was developed, how they collected information, what was the specific way they got referrals, things like that. So what we're doing today is we're going to give you a broad overview of this service that we're talking about, the Concurrent Specialized Youth Hub. And we invite you to ask questions about any and all of those things afterwards, or we're happy to chat. And we've added our contact information at the end. So I'm going to let Renee start with just a little bit of an overview of our agency to provide context to how we came to do this work.
Perfect, thank you. Hi, everyone. So I wanted to start by sharing, when I first started at Wyndham House 6 years ago, we had 120 chronic homeless youth, and this week we have 4, and we would have not have been able to do this without all of these services that we have. So we have a transitional housing program that typically we're seeing youth stay with us anywhere from 3 months to 3 years at a time. This year we open up a permanent supportive housing project, which is going very well, and we're very happy about the work that we've done there. We have a youth emergency shelter, rapid rehousing and diversion program, a Section 23 school, which is in partnership with our school board that we have in Guelph. A trustee program and rent supplements, which is either a small rent supplement for a shorter period of time or longer term supplements for youth. a case management team, so a team of 6 housing workers that support youth, and they have anywhere from 12 to 25 youth on their caseload at a time. And then lastly, our concurrent youth hub, which is hopefully kind of our last stop in ending youth homelessness in Guelph that we're here to talk about today.
Oh, and I meant to mention, so little personal note, I went on maternity leave this year. So I started this project. I went off, Renee took over, and then I came back and did some work. So we're going to be jumping back and forth. That's because we had different roles in this project over time. So sorry about that, but hopefully it keeps you more engaged anyway, because it's boring to listen to one person talk for a long time. So how did this come about? So as Renee said, we were really working with our local service manager for many years around the issue of youth homelessness in our community. We solely focus on youth homelessness, and we're very data-driven in the work that we do. And we found a lot of success when we introduced diversion interventions. We found that that was really successful in keeping young people with less complexity out of the system, and in safer, more appropriate housing placements. However, we recognized that there was still a subpopulation of young people we were working with that we could not find resources for. So similar to the narratives we heard from the other two presentations, primarily young people with co-occurring mental health and substance use concerns. And I see lots of nods in the audience. This is a population that, historically we've struggled with quite a bit. And interestingly, we developed with our local drug strategy a concurrent disorders working group focused on youth. And we noticed that lots of other service providers had different vantage points into this problem. So whereas we were seeing the issue from a homelessness perspective, our local child adolescent inpatient unit was seeing an increased number of young people with substance use disorders ending up in the inpatient unit in Kitchener, whereas in Kitchener they weren't seeing so many of that population. So they said, what's going on with Guelph? And so we kind of got together, and there was this idea at the time in Guelph to create a day treatment program for youth. There was, few options in terms of day treatment, so they wanted to create one of those structured, maybe 8-week day treatment programs. And myself and Caitlin, who's in the audience, who came from the Cape unit at the time, we both went to this meeting. We said, I don't think that's going to meet the needs of the population that we're focused on, because they won't go to a structured 8-week program. And so we started developing a different idea, which is around the concurrent specialized youth hub. So some of what we were seeing and what the partners were seeing was that it was the existing health inequities. They just were very much more apparent during the pandemic. I remember very saliently a day at our emergency shelter when we were experiencing a young person with a really serious psychotic episode, and we were trying to provide support, and they were supported by a different agency, and we called, and they were trying to give our shelter staff advice over the phone of how to provide support to that population. So I think that just really showed us that we needed to tool up our own ability to respond to these needs within the context of our own system. So we also were seeing a significant increase in sentinel events for this population, particularly overdoses, but also situations of violence or these sort of critical incidents related to potentially crystal meth use. And then we just recognize that there's a need to look at homelessness as a healthcare issue, and that we needed services to happen in a coordinated and concurrent, capable way. We were seeing young people who had 6 different service providers, and they all felt very light touch. Like they were seeing someone once every couple of weeks, they were missing appointments, going to the hospital, no appropriate discharge plan, and it was very cyclical, and none of the service providers were really meeting the need where it was at. And also this issue of kind of people who are in a contemplative or pre-contemplative state around their substance use, that there were very few options for them other than just perhaps providing harm reduction supplies. So really thinking about how can we provide support, treatment, holistic intervention for people who are at different phases in their substance use. Is this me too? Yeah, okay. So we started with a 1-year pilot. So because there was so much investment from our partners, everyone was seeing sort of we needed to do something. We were able to get support from a couple local partners and some year-end funding to introduce 1 concurrent clinician, some limited psychiatry hours, and some in-kind support from a nurse practitioner. And that was kind of our jumping off point. That helped us identify, okay, what what pieces of the puzzle can we address through this service? How is it working? What are we going to evaluate? And then we were able to do a larger application through SUAP, that's Substance Use and Addictions Program under Health Canada. So it's a federal grant. And that we were awarded $1.2 million for a 15-month grant, which has since been extended to March 2024. So we were able to do really an intensive intervention over 2 years. And that's how we were able to kind of implement a fulsome intervention plan, which we will describe. We did want to make sure that what we were doing was really aligned with some of the issues that were coming up in the healthcare sphere around how to improve access for populations. So we were focusing on urgent issue management. So we needed to make sure that the service provided immediate access to support at critical moments when people were asking for it, not, okay, sounds like you want help now. In 3 weeks, we'll meet you at this location. That doesn't work. Enhancing collaboration and communication between healthcare services and sort of streamlining those services in a meaningful way. We also felt that screening and assessment was really important because particularly when you're talking about adolescents, they may have had very limited interactions historically with the healthcare system and they're just having new interactions, or perhaps if there's existing mental health issues, they're actually just coming online or evolving in some way. And so there's a need to kind of understand what was actually happening for that young person. And we wanted to look particularly about the intersection of concurrent disorders with developmental disabilities and neurodiversity because those were subpopulations of individuals that we were having trouble getting access to support for. And then we wanted to have clinical supports that were complex capable, that weren't sort of creating all these exclusionary criteria that we were facing when we were trying to get support for that population. And then thirdly, preventative care. So we were hoping that through providing this appropriate timely intervention, that would adequately assess presenting an emerging issues and addressing these untreated issues, we would prevent the sort of movement into chronicity and severity that we were hearing about kind of in the adult system. And hopefully the outcomes would be increased diagnostic clarity and appropriate crisis support, prevention of chronic and severe health outcomes, and preventing sort of a graduation into that severe specialized care need in the adult population that we are seeing, young people we serve end up in the homelessness system chronically as well as the justice system.
Okay, so our eligibility criteria is quite simple. So significant co-occurring mental health and substance use related concerns that require specialized capable care, and that other services have been tried and are not appropriate or sufficient due to complexity. So if a client can access care through their family health team, then that and it's totally appropriate and other needs are being met, then we would go that route. Otherwise, our service would not be needed. And we do really attempt to reserve space on our team for the most complex clients with the greatest depth of need. Over the past year and a half, we've also seen people be quite confused by our criteria because it's so broad and quite simple, but we've actually been able to meet all the people who were not serviced for many years through this eligibility criteria. So this is our full team that we have at our Concurrent Youth Club, and some of our folks are sitting in the audience today, which is very exciting. So we service, so we have a nursing, primary care, we do assessment and treatment, so we have 3 concurrent clinicians that are supporting youth who are struggling with both, again, mental health and addiction. We have psychiatry and addiction medicine. We've been able to do 7 psycho-eds with folks that have been able to get them access through developmental services through this grant that we received. We have case management and family support, program implementation coordinator and site coordinator, and they kind of are at the site doing programming and managing some of our EMRs behind the scenes for the folks that we're working with. And through all this work, we're using a harm reduction lens for servicing the folks that we're working with, regardless of where they're at. If they want to keep using but want to try meds maybe for the first time or get some wound care done, we're able to do all of that at the hub. We also have the clients that come to us sometimes are only touching one of these services or need all of the services, and at times we can see that the psychiatry is only needed for a period of time and then they're closed and then the nursing's taking over after that, or if they have an incident in the community, psychiatry can jump right back in. So the file's never really closed. We're just kind of working with the team weekly to assess what the needs are of the folks that we're seeing. So some of the key service design elements here, we just use a very, very assertive outreach approach. So we're always asking folks what they need. We are pounding the pavement with the folks that we're working with. We're going into sites. All of the team that you saw before is going into our housing programs as well. So the youth don't have to come to us. Our psychiatrists, our nurse, our concurrent clinicians are meeting folks in their home, whether it's be our permanent supportive housing project, transitional housing. Our psychiatrist has went to the shelter before when we had a client who was obviously not interested in seeing a doctor, but we were quite worried about them. Yeah, as I said before, we use a multiple EMR system, so it's helped drastically with ensuring that we have the accurate most information, although we would like if it was one, but for the sake of kind of ensuring that we're gathering the most appropriate information, it's been quite effective. And as I said, with the rolling caseloads, not everyone has to be connected to all of those kind of 6 positions. We can just use them as necessary.
So the timing of this presentation is interesting because within the month, we'll have a fulsome kind of review of this service that was conducted by the research shop at the University of Guelph. So we don't have a fulsome review yet of all of our outcomes, but we have some that we've been collecting internally since the initiation of the project. So essentially, there's sort of 3 kind of focus areas and then a few outcomes that we've seen so far. So the first was integrating all of these services into one site. So we took our existing homelessness services and integrated it with this healthcare team. So it's one team. And so some of those services are still funded through Reaching Home or other kind of pathways. They're not working kind of alone in a silo, just doing sort of this healthcare or this case management piece. They now have a team of mental health professionals supporting their work. We also were able to physically transform the site so that it was more appropriate. So whereas we had a very traditional kind of drop-in center site historically where it was like one big open space, we created more breakout spaces for people to have peace and calmness, to rest, spaces, primary care space, clinical room. So there's sort of more different intentional spaces within our setting. And then also, as Renee mentioned, using different information management systems. So whereas we used HIFIS historically as a homelessness serving organization, we use HIFIS, but we're also connected in with our local health centers information, and that's what our nurse practitioner uses and our RPN. And then we are also connected in with CaseWorks, which is what our local mental health agency uses. And we talked about the program implementation coordinator. That person actually helps. They almost act as a medical assistant, and they sort of ensure that that information is translated across those different EMRs where appropriate, so that whoever's providing service to that population is able to actually see what's happening and who's connected, because that was a big barrier that we were seeing. We also are providing lots of psychoeducation around harm reduction methods for the population we serve, and also we've been doing some training sessions for other population or other service providers around how to be more complex capable or address concurrent issues. And then we're providing wraparound complex capable treatment and support. And so far what we found is youth and community members have a greater knowledge of harm reduction and access to supplies and resources related to that. Information is shared across service providers for more seamless service. So when someone walks into CMHA or Here 24/7, which is our local sort of emergency crisis line, they can see that we're connected to the client, there's a warm handoff, et cetera. And youth who did not have access to primary care have a full team of supports and experience fewer adverse outcomes, the sentinel events that we were talking about, greater life stabilization, so that's things like being connected to education, being housed, and greater engagement and meaningful activities of daily living.
Okay, so the last piece of our project is our integration with individuals with lived experience. So we work from the framework of nothing about us without us, so ensuring that none of the voices that we're servicing are missed. We have a monthly youth advisory committee that is hosted by our peer worker and our site coordinator, and really interesting, some previous people who used to live at Wyndham House are now on our committee as well, doing some of the work. And we're talking about both issues at Wyndham House that clients are experiencing and in the community as well. So most recently, we wanted to share a situation that, as many of you guys, I'm sure, experience. We have experienced drug poisonings in the bathroom of our hub before, so we actually went to this committee and we're super worried. we understand that you guys are going to use, but we just want to keep you safe. So they actually came up with the idea of making a poster that they made. At 5 minutes we knock, and at 10 minutes we open up the door. And there's a sign on the door, and it's very like youth focused. And we've been able to save lives also that way with situations that have happened in the bathroom. And then lastly, our peer worker works kind of a different schedule than some of our other housing workers. They kind of work a 10 to 6, so they attend AA and NA appointments with our clients, and that's both supportive of our peer worker and the clients that they're supporting. They visit encampments. They take a lead on harm reduction approaches across all of our programs. And yeah, so a lead on harm reduction. They're often offering harm reduction supplies to all of our folks in the community and in our programs as well.
Okay, key takeaways. So this is what we think is really important about what we've learned from embarking on this project over the last 2 years. So the first is the integration of a health service within a homelessness serving agency, because we're able to center kind of the idea that housing is a basic human right and everyone needs housing in the way that we approach the healthcare services that we provide. And it allows us to be more complex capable across all of our services, our shelter, our long-term housing, and our supportive housing. We found that the process or the way in which we're providing care is very important. We found ways of doing psychiatry that allows for us to not have missed appointments. I can tell you more about that if you're interested. And we really work with the voices of the individuals with lived experience that are advising us around how to not reinvent basically the same systems that we're trying to kind of work to improve. So we're always kind of checking in again, okay, we want to create this new process, but is it going to create a barrier, unintended barrier? So we kind of work on that together. Really the importance of being complex capable and not saying, okay, we don't do that, or if you have this diagnosis, we can't do that. That is just the crux of the issue that we're facing for this population. And the last is just, I think, with what's going on across different provinces in Canada right now, this idea of kind of harm reduction versus treatment is sort of arising more, this discussion. And I think it's really harmful to the population that we're trying to serve. So just this idea that harm reduction and treatment can both be provided to individuals at various phases of recovery, and not saying it should be harm reduction or should be only treatment. Obviously, providing both at the same time in the same place has been very, very effective for the population that we support. And we meant to have our contact information, but I think this is the old version of the presentation, so let us know if you want to be in touch. And we're also happy to share the product that we create with the University of Guelph in the coming weeks if anyone is interested in that.
Thank you very much, Christine and Renee. Thank you to all our presenters for today, Matthew, Stephanie, and Sandra. Now we go to the Q&A session. For the question and answers, I'll please ask that if you have questions, you go to the mic, particularly for the sake of our virtual audience. So Q&A now.
Thanks. So this question's for the first presenter, Sandra?
Okay, Sandra.
Perfect. One thing I just want to say before the question, you mentioned 911 calls to your area. When we were establishing the Safe Consumption Site and Drop-In Center in Saskatoon, we made sure to differentiate between police calls and calls for aggressive or violent incidents and medical calls. And then it allowed us to show positive outcomes on the crime prevention side because crime calls actually dropped when we opened up, and so then it really allowed us to build good partnerships with the business community because then they were starting to ask us to expand even in places like downtown where we weren't really wanted originally. But my question is on the standardized training for your staff for conflict de-escalation. Is there like a specific program that you use, or is it kind of like a homebrew, or because we've dealt with this quite a bit in Saskatchewan where we've tried to adapt and implement, and I think they have a SUAP grant right now to adapt existing training programs so that they can better address people's behaviors who are in psychosis on crystal meth. So just what's your guys' approach on that?
We scrapped all the existing de-escalation programs and created our own. So the person who's doing case management for our program is also one of the best well-known social activists in Toronto, Diana McNally, who's also one of the co-facilitators that I've done most of crystal meth trainings with. Basically, we created a custom-made training for our space, and then each agency that invites us, we custom-make training for their specific space. So we delivered agency-wide training, for instance, for Gerstein Crisis Center. Like they do community interventions with people experiencing mental health and substance use issues, but they also have supportive housing. And the reason I'm saying this, it's really, we forget about going back to basics. So individualization, right? Like working on establishing a relationship with a person, like not even in the context of drop-ins. I've responded to crises in our neighborhood with people I've never seen before in my life, and it's not because I'm a hero, but like because I really get it, that people are acting out of fear. I'm not uncomfortable with the behaviors they're exhibiting. I'm not intimidating. It's usually about like one de-escalation I responded to, like 6 cruisers showed up because this tall gentleman was throwing garbage bins in the intersection and stopping traffic. And like right before they exited, I managed to exchange 3 sentences with him. Basically, I told him who I am, why I'm talking to him, and is there anything in that moment that I can provide to him that would make him feel better. He needed socks. He was barefoot. It was hot, you know, but nobody's asked him that. Like there was 30-minute period where security was approaching him, you know, when other people were intervening. So it's really, and I'm just showcasing this because this is what we teach people, right? Like, don't focus on behavior. Focus on your discomfort level, your fear, and the other person's fear. If you're bringing down the fear aspect, de-escalation is most likely to be successful. And you'll do trainings with your staff who have these frequent interactions very differently than with someone in hospital setting who only does this periodically, or who might work in an environment in which there's an extra amount of stigma around substance use versus an overdose prevention site in the community. So teaching your staff about how to talk to clinical staff or like police officers, it's no fun, but it's very effective, right? Like reminding people that other people come from different
Follow
backgrounds.
up on that then is, sorry, last thing. Follow up on that then is, like, because I deal with the same thing in Saskatchewan where I get asked to go around and train everybody up, and the scalability on that type of approach is really limited, you know, and so just potentially, I would encourage you to develop a train-the-trainer program so that it isn't just based off your organization going out and doing it, because we ran into the same problem in Saskatoon and now in Western Canada where we get asked to go out and go do trainings, but it's always specific on the staff member. And so that train-the-trainer model where a group can come in from several organizations, train out, and then go, yeah.
So the training I mentioned that Ontario Harm Reduction Network did, in my opinion, was really fantastic. They scrapped it last year because we did it in 2017, so it was starting to feel a little outdated. That training consisted of 2 components, like general crystal meth use training, person with lived experience without problematic use, and then working with homeless population and lived experience with homeless population. And my hope is that we're gonna do something on that scale again, because I feel something that's virtual and that's kind of general like that is then accessible to any individual, even outside of their organization, and it's free.
Awesome, thank you.
My question's for the important work that's being done in Montreal around the partnership between your 2 agencies and the managed alcohol program. I want to comment what a dignified approach to supporting what we're finding in Kitchener, Ontario, often a increasingly forgotten about subset in our communities, especially in the context of increasing drug poisoning crises. So bravo. We see significant gaps for this population in Kitchener, and are left to try and support them individually in homes around their unique needs, which often leads to them dying alone. So lots to take away there. My question is around polysubstance use. We see many of the people that we support who have historical alcohol addictions with increased access to now crystal meth, fentanyl, are starting to use and become dependent on new substances. I'm wondering what your capacity to support people within your program is who have polysubstance use disorders, and if you do have capacity and experience around that, what are the outcomes in terms of specifically seeing reduction in crystal meth, fentanyl, and people returning just to their historical substance of choice, which would be alcohol? That's my first question. And then the other question is there a way to get the alcohol covered just as any other prescription for this population? Thank you.
Okay. With regards to the first, can you hear me? Yeah. Okay. With regards to the first question, we've had a few participants who were using other substances. Crystal meth is starting to show up in Montreal, but it's not to the same extent as other cities, but it's starting. So we're seeing mostly a lot of fentanyl and crack. That's really affecting PAC's community members. So we've been trying to accommodate people who have polysubstance use. We've had some positives, but also we've had some some difficulties as well. I think with opioid use, because there's Suboxone and methadone, that is certainly helpful. And so one community member that was using fentanyl and other opioids was put on Sublocade and really helped quite a bit, and he was very happy with that. And so that has been really helpful in stabilizing his substance use disorders. He's still drinking, but he's doing okay. We had one participant who with a crack use disorder, and we tried to help him quite a bit and to support him with that. But it was tough, and in the end, after a couple of years, I think he did leave the program, unfortunately. And he's using some of the other resources at PAC, but within that setting, it was a little more difficult for me. Matthew, can you add to that?
I'm just getting echoes that people aren't hearing us.
Oh, okay.
So I'll try to speak louder. I don't think our mic's on.
This one might work.
Yeah, so the gentleman who left the program, he's still in contact with us. He's still in the community. We have developed that good relationship with him, which means we're still working with him on many aspects. And he still remembers his time at the house very positively, and he thinks about going back often. What was your second part of the question? The alcohol coverage.
Yeah, in terms of coverage.
So the alcohol has never been covered as prescribed. The way we sort of work with it is seeing that the housing is subsidized. And then the program also, like our organization covers another part. So the residents of the MAP program, they contribute for the rent, which includes alcohol and meals and other services.
What's that built right into the alcohol?
So it's sort of built into it. So the organization is paying for some of it. The participant pays for a portion of it. And then with the subsidy for the housing itself, it sort of makes it something that's more affordable for the participant. It's still quite expensive for them based on their revenue, but it's something that's more reasonable than if they were paying for the whole alcohol use on their own.
Nice work, thank you.
Any other question?
Hi, can you hear me? Thanks. Thanks, everyone. This is for the last group. I was just struck as you were talking about the emphasis placed on kind of psychiatric evaluation, diagnosis, and as I see it, that can be a bit of a double-edged sword. We know that for some people, receiving diagnoses can be really affirming, and labels like bipolar and schizophrenia can provide a useful framework for understanding. And conversely, for others, they can be profoundly disempowering, and exposure to psychiatry, and particularly like really rigid biomedical explanations of thoughts and behavior can be internalized, can lead to, I think, cycles of disempowerment, et cetera. So I'm wondering how you kind of embed safeguards in your programming for people who don't who are resisting diagnosis, rather than simply say that they are treatment resistant, or my favorite, lacking insight into their condition. Like, how do you mitigate kind of those tensions? And if you have someone who says, no, I don't want to be called X, Y, Z, how do you ensure that their needs continue to be met?
Yeah, that's a great question. I think in several ways. So the first would be that we don't, not everyone in the program accesses psychiatry. If it's not a priority, an interest, a focus of anything that they're asking for or that they need, it's not integrated. And then secondly, the psychiatrist we have is embedded in a harm reduction approach, and he's quite trauma informed, so he doesn't focus on label. He'll often say, like, it's not relevant to label the person. Sometimes it's more of a focus on medication that can help with symptom management if that's something that the person is interested in. So certainly, like, one issue that we've dealt with a lot is the intersection between a person with ADHD that has been historically treated with stimulants. Now they're using methamphetamine, but they may have an interest in receiving treatment for ADHD. So working with some of those complex issues that if you went to a different setting, you likely would not be able to go through that pathway necessarily to look at that. And I think the other piece where sort of diagnosis comes in that might be sort of an intersection between what the psychiatrist does and the psycho-ed assessments that we've sometimes employed is more around also intellectual pieces and neurodivergence. So like where that might be relevant, or we're trying to explore if there's, we need to look at the situation quite differently in terms of thinking about what else might be happening for that person, or even functionally how to communicate with them. One piece we didn't talk about a lot is we also use occupational therapy. And I didn't understand what occupational therapy was before I started this. I don't know if anyone else relates to that. But it is so fascinating. And as a social worker with a very clinical kind of, thinking, I find occupational therapists are so practical. They are so good about thinking about a problem completely differently. And so sometimes it's sort of the psychiatrist saying, I think there might be, this person has, severe kind of issues around executive functioning. This is impacting the way that they're having crises in these moments. It's not just related to their crystal meth use or whatever. And then being able to integrate perhaps an occupational therapist to work with the staff in our supportive housing program to come up with a plan of how we can support, environmental changes or something that could help the person. So there's sort of lots of different ways, I agree. Because I don't hear a lot from the young people about this issue of labels. I have heard it from more practitioners than I would say the young people we work with. But it's not really about the label, it's about functionally what can we do today to support you. And maybe a label is gonna help us understand, or it doesn't need to be a label, but just like a set of practices or a set of interventions that might be helpful based on a profile. And the last thing we do is we do allow not just our employees, but also other workers in the community to have appointments with the psychiatrist about a case. So they can also just ask for advice that's not related to having that client asking for that support. And again, that's just for sort of advice around how to functionally manage a particular situation or presentation. Yeah, but great question, thanks.
Thank you.
Thank you very much. Any other question?
Good afternoon or good evening, everybody. My first question is for Sandra. I want to know how you balance the client safety with the staff safety. I want to know what that balance looks like, and how do you implement that with your staff, and how do they go about processing their day-to-day lives? I know it's a factor of fear and awareness and stuff like that, but still there will be still kind of like a pullback there in terms of what that balance looks like. And my second question is for Montreal team. I want to know what an intervention worker is and what those roles kind of look like.
I'm I'm really sorry I had to rush through that part of presentation. I was told that everyone will have access to the slide decks we created, and I was very detailed in my slide deck, so you'll have like a breakdown of that, but very quickly, I feel like the crucial piece of change we implemented is we really shifted how we talk about incidents. And then that changed the buy-in from the team, and it had this snowball effect. So we separated wellness debrief. So how is everyone feeling physically and mentally post-incident versus incident debrief? So check in on the day of, like, how are you doing? What do you need from the rest of the team? We do not talk about the client, behavior, any of it, at least 24 hours in between. And then we actually had formal training about how to control our language when we're talking about things that are really emotionally affecting us. And I mean, at the end of the day, we're all humans. Doesn't matter how patient and loving you are, there will be situations that trigger us. And I mean, the reason we focused on these things is because we have more control over the knowledge and supports we're offering staff versus community members. So words like violent, dangerous were not allowed anymore. It was like a very cold, hard, clinical, like this was the situation, these were the circumstances, this is what we did. How do we do better next time without assigning any blame? So no talking about like so-and-so did this. It's like, no, were there any things that you thought of later that you think would have helped prevent or de-escalate things? The other pieces, we started involving community members in the conversation, not on the day of the incident, but later on. It was like, what was happening for you? What did we do that contributed to this? What was the part that you felt that we didn't handle so well? And I know it seems basic, but people taught us like such incredible things that then helped inform how we're going about interacting with them. And then the third piece was we introduced a wellness check-in for clients as well. So instead of them coming back and us being, this was your behavior, this was your consequence, we built into our community that the first thing we're gonna ask them when they come back is, how are you doing? What happened after you left here? Like, are you safe? Are you okay? It shifted the entire dialogue around consequences. And when we asked people, like, what do you think would be appropriate consequence for your behavior? They were much harder on themselves than like any organization would be. So we haven't had a service restriction in about 6 months now. Like not a single one, like none. And I mean, I know this takes time and energy and patience and a lot of work with staff, but it works.
Thank you.
Just very, very quickly to answer your question for the intervention staff. When we hire for MAP, we often explain to the candidates that part of it's intervention, part of it's a barman. So the intervention aspect is being a presence in the house, being there to listen, being there to sort of go with the residents on a day-to-day basis, reminding them, have you eaten today? Let's make breakfast together. Sharing stories, creating the group atmosphere, and of course the other aspect is serving the alcohol. So every resident has their own plan based on how many drinks, how many pours throughout the day. The intervention staff are there to serve them as if they would in any other bar, making sure that at every pour, of course, evaluating the level of intoxication, making sure that they're not going to withdraw. If they have lives, they can leave the house. If they've gone out and had alcohol from outside of the program, when they come home, we evaluate again to see what's their level. Do we serve another? Do we wait? So there's a lot of evaluation done, a lot of coaching on what are the signs of intoxication, what are the signs of withdrawal, making sure the residents feel comfortable.
Thank you. We'll take the very last question, one question, and then we'll wrap up.
So mine is a twofold question. First part for Sanda, and then the other part for Wyndham House. So with the use of crystal meth and also concurrent mental health disorders such as schizophrenia, the likelihood of that occurring within somebody who has schizophrenia and other mental health disorders is increased almost tenfold. Is there any training or formalized aspects of looking at that and connecting them with supports or connecting to them on a personal basis to speak on how that might be affecting them in the moment, or if there is a way to distinguish those symptoms between the psychosis even though it is quite difficult to do that. And then the second part of the question is, with substance use and young people, there's a higher chance of self-harm behaviors and stuff like that, especially with those who are unstably or precariously housed or living on the streets itself. So the question there would be, is there any supports in place to do harm reduction supports in aspects to self-harm or other self-harm behaviors? And if so, is it in the form of other supports and outreach, stuff like that, or is it more harm reduction as in like wound care kits and also treatment aspects combined?
I'll try to be very quick because you asked something that I'm super passionate about, and I'm actually building into my current research design model. I've been doing this work for 8 years, including clinical work with a psychiatrist and a physician that I couldn't include here because there are funding limitations. But the theory that we're trying to gather data on, that people, whether with diagnosed or undiagnosed psychiatric conditions, not just schizophrenia, but this includes ADHD, bipolar, blah, 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 at least among our population, are more likely to experience psychosis as a result of crystal meth use. And I think this is very, very important for our work, precisely because when people present with psychosis due to crystal meth use, even if they might have underlying schizophrenia condition, at least in Toronto, they get discharged, even from our Center for Mental Health and Addictions. The other piece is we're working with a physician who I don't think is an accident that he started our managed alcohol housing in Toronto, who's also the first physician who's exploring substitution therapy, like prescription for crystal meth use. So we've been using dextroamphetamine for the last 5 years. Again, limited research, but that substitution therapy and interactions with other psychiatric medication and psychiatric diagnosis, again, stay tuned for more data, or if you want access to that information, just email me.
Also, we're also very passionate about this. And two things that have worked for us in relation to this is just treating the psychosis. So if you have medical professionals that are willing to do that, you can see if it's effective. Like, you can try medications and see if they're effective for people regardless of their substance use. And the second is something that we've used for sometimes situations where it's in, there's an incredible difficulty and they're in and out of hospital a lot, is if somebody is intersecting with the criminal justice system, which we would never want, but sometimes unfortunately occurs, is working with that moment to potentially ask the facility to provide feedback on their presentation when they're incarcerated and potentially try new medications during that time as a way to sort of get rid of that argument. And then we've been able to bring that back into our local hospital system and say, okay, well, when they were incarcerated and they were not using substances, which, I mean, who knows, but we use that as kind of an argument sometimes to get better care, and that has been effective at times.
Okay. Yeah, and it's a wrap. So I want to say a big thank you to all our presenters and the participants. Please be reminded that there will be a recorded session of a recording of the session. It's going to be available on our web conference web platform. Thank you all for coming.